Welcome to the second event of Day 3 of the German-American Conference. We are so excited to have you all join us for our discussion, Mental Health and Why We Need a Change of Perspective. I am Debbie Berdinsky, one of the conference organizers this year. I wanted to give you a brief overview of our event. Dr. Rick Wolthusen will start the event off with an interactive exercise in which we will together brainstorm solutions to the current state of mental health in the United States and Germany. Dr. Wolthusen is a psychiatry resident at Duke University and has received a Master of Public Policy from our very own Kennedy School at Harvard. He founded the German NGO On the Move e.V., which empowers local communities to take care of their well-being and mental health. Dr. Wolthusen also works with the local and international governments on community mental health challenges and mental health legislation. In part 2 of our event, Dr. Vikram Patel will share with us how the approach to mental health care in low and middle income countries could benefit the German and US societies. Dr. Patel is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow at the Harvard Medical School and a trained psychiatrist. He has pioneered several initiatives on global mental health, for example, as a co-founder of Sangath and the Center for Global Mental Health at the London School of Hygiene and Tropical Medicine. He also is a fellow of the UK's Academy of Medical Sciences and has served on the committee which drafted India's first national mental health policy. At last, we will wrap up the event with an audience Q&A, in which you all will get the chance to hear Dr. Wolthusen's and Dr. Patel's thoughts on some of your most pressing questions. You can post your questions using the Q&A tool on Zoom throughout the event, and we will do our very best to get to all of them. We organized this panel because we believe that solutions to the mental health crisis exist that we not commonly think about. But we have to think outside the box to address this crisis. Together, we may be able to uncover possible solutions to change the future of mental health for the better. In addition, our societies have a lot to learn from global mental health approaches, such as those in which community health workers and ordinary citizens lead mental health initiatives for those around them. We invite you now to participate in this interactive discussion with our two renowned experts in this field. And we'll turn it over to Dr. Wolthusen to get us started.
All right. Good morning, everyone, and welcome to the panel. I'm currently in Kenya. That's why there's already light on here because it's getting dark already. But I'm really pleased to be part of this panel and to share this panel with Vikram. And thank you for the invitation for this very important topic. And as Debbie said, we are going to make it interactive. So let me share my screen. All of you should also be able to see the link in the chat. And I want you to go to www.menti.com and use the code. And as you can see, people already started to put in some words. Use this code up here, or you can also use the link in the chat. And let's just give it a few seconds. So what comes to your mind when you hear the words mental health? Just give it a few more seconds. All right. Well, I think we get a good mix here between some mental health conditions. We see depression is prevalent. We see suicide, which can be a consequence of a mental health condition. We see protective factors and risk factors. We see factors like peace and quiet, which could be a protective factor. We see potential risk factors such as peer pressure and stress. We see stigma, which is very prevalent in all societies around the world when we talk about mental health. And we also see, exercise, which is another protective factor. Gratitude, burnout, neglect. Okay, well, that's great. Really wide range of ideas you came up with. Now, when you ask a neuroscientist or a psychiatrist what they think about when it comes to mental health, and this is just one way of looking at it. But I think we always, when we explain mental illness or mental health to our patients, we think about this in terms of a jam jar, which is like depicted here. And the jam jar can be filled with different elements. There can be genetic factors, as depicted here with this like yellow bulb. And then we can have environmental factors, as depicted here with these orange triangles. And both factors, now the genetic factors and the environmental factors, can now fill up the glass. And someone is unaffected or doesn't really experience significant symptoms until the glass is full, right? And as you can imagine now, you can fill up the glass with genetic factors, things which you cannot necessarily change because your genes cannot be changed, at least at this point for the majority. And then you can also fill up the jar with environmental factors, as we see them here. Environmental factors being factors like traumatic child experiences, or adverse child experiences, not only traumatic ones in nature, but also experiences such as child neglect, things like doing drugs, things like stress, things like other risk factors such as being discriminated against. And so once the glass is full, people start to experience an active episode of illness. On the other hand, we can now think about, well, how can we prevent mental illness? How can we recover from mental illness? Well, I guess there are two ways. Either we remove some of the environmental factors from the glass, or we replace them with like protective factors, which is the second way, by just we think about protective factors as a kind of like we're adding additional rings to the glass and just make the glass taller so that we can tolerate more. And if we tolerate more, then mental illness doesn't come on again. So this is like one way to think about, I think, mental health and mental illness. And this all like accumulates in the idea that mental illness is really not about the biological. There's not one gene which is causing mental illness, but really mental illness is a complex phenomenon of like biomedical aspects, such as genetics, which we talked about, but also psychosocial aspects. Like, we see behavioral factors. This can be role modeling. This can be learning when growing up. This can be how we approach and cope with stress. But this can also be political factors, legal factors, economic factors, but also like social and cultural factors. So really, we look at mental health, what we call through a biopsychosocial lens. And as you can imagine, each culture or each country, even within one country, there are differences between all these factors. And so it shouldn't take you by surprise that the approach to mental health and mental illness, there's not a one-size-fits-all approach, but really it needs a really targeted interventions and tailored interventions based on the cultural context. Some elements are surely universal and some elements are not. And I think today we are going to talk about some elements from Germany and the United States. And we will also hear from Vikram what we can actually learn from other contexts. On the other side, one I just want to point out, because I think people always forget this. I mean, that's really good news, right? Because if there was one gene which is causing mental illness, like once you have the gene, you get sick. But the good news is, again, mental illnesses are not only genetic diseases. Mental illnesses are really diseases where we have genetic factors and environmental factors. And the good news is we can change the environmental factors. Sometimes we can change them ourselves, like we are in charge of our mental health. And sometimes society as a whole can change them. And this is really good news, because we are not, once we are mentally ill or unwell, we are not determined to stay mentally ill or unwell, but we can actually change this. So now, let me ask about some of these factors. You just heard me talking about biological factors, psychological factors, social factors, cultural factors. Can you give us some risk factors and protective factors as you see them in terms of mental health in Germany and the United States? And these factors can be the same factors on both sides of the Atlantic, or they can be different factors because you experience, some factors exist more in Germany, but not in the US, or vice versa. So if you wouldn't mind, put in some of your ideas where you can, for example, say RF as risk factors and then colon, and then just write something and make sure, that you maybe indicate, if relevant, if this is the risk or protective factor in the US or in Germany, if you are doing it right now already. Yeah. usually. Yeah, it's great. That's really great. I think overall, when you look at these factors, you can now again see that you have some psychological factors, right? Like about social security, also about like how we relate to other people, being isolated, being lonely, partly due to the pandemic, which is ongoing right now, which puts an extra burden on people. And I also want to acknowledge that people and students, for example, in the US right now, from Germany, who cannot go home or couldn't go home in the past, also had additional mental stressors. And obviously, this is not only true for students from Germany, but from all around the world who are studying in the United States. And then you also bring up stereotypes, very, very important, violence, discrimination. And this now gets really, also into the weeds. Medical care is very expensive in the US, into the weeds of like different systems, right? Like how different systems are built. I think, the things which are really relevant, it comes up here again, security, shelter, food. There are actually like a few studies showing that people in the US, about 50%, if you take one sample, I mean, I'm sure it differs between samples, but sometimes you see studies showing that as many as 50% of a study population who experience depressive or anxious symptoms, these symptoms can actually relate to insecurity related to the neighborhood, to insecurity with the neighborhood, to food issues. We see the issue of medical care, which is very expensive in the United States, which also goes along with the issue of, some doctors in the United States don't even accept some insurances. Like they don't accept Medicare, they don't accept Medicaid. We have the issue of ethnical, racial disparities in the United States. We have the issue of immigration in Germany. We have the issue of being a student. So I think you identified many of the risk factors and protective factors on both sides of the Atlantic. But I hope you also understand, without going into many details, but I also hope you understand how like certain historical and social aspects and psychological aspects on both sides of the Atlantic can now also contribute to mental health and mental illness. Now let's move on to the next question. How do you then take care of your mental health? And this particular question is about your own mental health. Yeah, great. That's really cool. I think what stands out for me is that, for some people, there are ways of taking care of yourself where you yourself can become active, right? Like you use your own coping mechanisms, your own coping strategies. You can do sports, you can prioritize your needs, you can spend time with your family, you can also take time for yourself, you can do some physical activities. And then on the other side, there are also ways of taking care of or being helped by people around you, right? I mean, just speaking with friends and family, I think I might also mention this when I talk the individual aspect. But really, I think, again, as much as there is not a one-size-fits-all approach when it comes to mental health and mental illness, there's also not a one-size-fits-all approach when it comes to like how you take care of your mental health. I think all approaches are valuable as long as you really, just engage with them. Because I think oftentimes, one of the aspects I talk about quite often with my patients is that we don't really think about mental health until we are mentally unwell. But I think at this point, it's kind of too late, because we cannot think about how we are actually doing once we are unwell. We need to start thinking about our own mental health in stages where we are still feel mentally healthy and mentally have the capacity to think about these things, right? And so I'm really glad like people do these things. Now, let's look at how we can support other people's health needs. Once we take care of our own mental health needs, how can we support other people? And is it even important to support other people, or you think if everyone takes care of her or his or their own mental health, it will be fine? Just talk. Yeah, I like the just talk. I agree. I think talking is great. Oftentimes people, when I talk to them, they just say, I don't know what to say. I just feel inhibited. I feel like if I bring up the topic of mental health and then someone is telling me something, I don't know what to say, right? And so this is why I don't just approach the topic at the first place. And I think, part of it is be proactive and listening actively, but also know your boundaries. And I think you guys are really hitting here on the main aspect. And I think, a lot of the things you're saying here right now really goes back to the idea of psychotherapy, right? I mean, not all of us, like in fact, the majority of us doesn't necessarily have a degree in psychiatry or in psychology, hasn't taken formal classes about how to offer psychotherapy sessions. But I want to encourage you, and I want to say, a lot of the things we actually teach in psychotherapy relate to like human intuition. Like a lot of things we do are actually the right things to do, right? If we really proactively listen, if we don't judge, if we give space, if we have boundaries, if we help, this is really like these are very important aspects of taking care of other people's mental health needs. And I think, this can be easy or not. Sometimes it's not. And there are mental health first aid classes, or like in this case, it's not so much a first aid class, but it's called mental health allyship program. It's one of the things my NGO offers in Germany. We purposefully said we don't want to have a first aid class, right? But the idea is it's almost like structured like a first aid class, like knowing what to do if someone has a mental health emergency, but also just knowing how to talk to other people. And so, things we teach in this class is like, how to pay attention, what are some of the warning signs, how to approach the conversation with other people, how to accept other people, how to be authentic and not just, say statement after statement, and then also how best to advise an option and what to do. So I really encourage you, especially if you're German speaking, we're in the process of also translating it into English, but if you're particularly interested in this course right now and you speak German, then you can go to this homepage, aufeinanderachten.de. Now, let's shift our focus a little bit for the last couple of minutes. And I know this question can be, you don't have to answer it if you prefer not to say, but I just want to get a sense of like, the numbers in the room. And this is why we use Mentimeter, because no one can actually know what you responded to. Oh yeah, it's almost balanced between people who have been diagnosed with a mental health condition and people who have not. That's I really appreciate your engagement with this question, because as I said before, it can be a really tricky question, but also it shows that there is a lot of mental health need, right? And sometimes we know that the mental health need is existent and we can assist, and sometimes we just don't know, right? Because either it is hard for us to know what's going on, or we know what's going on, but we prefer not to say or engage with it. So I really appreciate your honesty. Now let's keep these numbers in our mind. We have about 9 people saying yes, 10 people saying no. So it's about equal. Now let's actually look at a similar question, but a little different. Like, have you ever felt that you're struggling with your mental health? Yes, no, or again, you can opt to not to say. Okay. Well, I guess we can wait until more people have voted. But I think the idea is clear, right? Not everyone needs to be diagnosed with a mental health condition to seek help. I think we are all struggling at times. And that kind of relates to the point I made before when I briefly talked about the idea that we are constantly on the spectrum between mental health and mental illness. And some days we feel very good and very healthy and on the spectrum where we are very mentally healthy. And then some other days we are really struggling. We feel stressed. We don't know how best to cope with it, right? And again, I just want to say and encourage all of us to think about how to take care of our mental health on these days when we feel good. And also just acknowledge and embrace that there are days where we just don't feel good. And if we have coping strategies and coping mechanisms at this time, I think this will go a long way. And you guys have identified really amazing resources for yourself and for community members how to take care of mental health. Now let's look at Germany and the United States a little bit. And I think it's also interesting because, if you look at Germany, around 25% of the population, adult population, I should say, is affected by a mental illness each year. I think our little sample, it was almost 50%. But we also know that student populations struggle a little more with mental health conditions, or maybe not struggle, but encounter more mental health conditions. The interesting thing is now, out of the 25% of people who is affected per year, only about a fifth of the people who are affected actually seek help. And then the overall treatment gap, and this is not each year, but this is the overall treatment gap. Treatment gap being the number of people who need mental health treatment, who could benefit from mental health treatment, minus the number of people who actually receive appropriate mental health treatment is 50%, right? It's almost like a coin flip. Only every other patient who is struggling or who is encountering a mental health condition is actually getting the treatment which is most effective. Most common illnesses in Germany are anxiety disorder, mood disorders, and disorders caused by alcohol or drug consumption. You can also listen to the podcast I did with Anne to get some more insight about this. By the way, the treatment gap in the US is about the same. It's a little higher, 55%, and we think some of it has to do with access to insurance. From the mental health conditions, it's about the same pattern we see, even though alcohol is less relevant in the United States, but it's really opioids, which are on position number 3, which is, probably no news to you, given that we have been talking about the opioid crisis for quite some time now. Mental illnesses in both countries are among the leading causes for the loss of healthy years of life. And, we also know that if you have a mental illness in Germany, it's about 10 years. In the United States, it's probably more about 12 to 15 years. It does shorten your life expectancy for many different reasons. If you look at suicide rates in Germany, we have about 9,000 suicides per year. So this is a rate age standardized of 8 suicides approximately per 100,000 people. The gender ratios, males die by suicide almost 3 times, a little bit more than 3 times as often as females. And this number is actually almost 1.5 times higher in the United States. So there are a few more suicides in the United States, even when we look at age standardized number. And then I think a very interesting figure now is how much is actually spent on mental health if you look at it. And I think as a matter of fact, the United States spends a very large amount, about 70% of its GDP on health overall, and about 5.5% of this 17% is actually now spent on mental health. In Germany, we spent about 11% of our GDP on health expenditures, and then 11% of the 11% are now spent on mental health disorders. So I think in general, we can say, it would be fair to say that the majority, that a lot of money is spent on mental health, and yet we are facing such a huge treatment gap. We are facing many people who are untreated. And the majority of the funding, about 80%, actually goes into psychiatric care as an inpatient and not so much as an outpatient. Just briefly about the United States, so nearly 1/5 of the US adults lives with a mental illness. Actually, there was a survey in June coming out saying that about 40% now struggle with their mental health related to the pandemic, related to the economy and whatnot. We talked about the treatment gap. We talked about the most common illnesses. I think 3 things to point out about the US is we see that the majority of people with mental health conditions are actually jailed. They're not found in a clinic, they're not found in a hospital, they're not found in community settings, but they're actually found in jails and prisons. We also know, and this is actually quite similar to Germany, that from the homeless population, about 25% of the homeless population suffers from severe mental illness, and almost another 50% have any kind of mental illness. And then the last aspect here is the deinstitutionalization of care, where in 1955, we had like 340 hospital beds, psychiatric hospital beds for 100,000. And in 2005, it was down to 17. And so the idea was, as much as we reduce the number of hospital beds over time, we build up a community-built system. The reality is, and these are the numbers you see above this number, so maybe I should switch the order, but the reality is that now the majority of patients hasn't found a community solution, but they're actually in prison or jail, or they are homeless. And so this is real. And again, we are spending so much money on mental health, and yet there's so much suffering. And so let me just skip ahead on a few slides. I'm happy to share them. We can look at students' mental health. We can look at mental health of LGBTQ plus individuals. We can look at people of color. We can look at American Indian, who all of them, by virtue of their identity, just have an increased risk for mental health. Now, this brings me to the last minute of my little presentation. And, now I'm asking again, where should treatment take place? Well, at some point we decided hospitals are not the place. And this is, when we started to reduce the number of hospitals. But then the question is, well, yes, we can treat now people in community settings, but how best do we treat them, right? And so this brings me to my final slide and just two concluding thoughts. Now, what is the future of problem solving? How do we start to think about this mental health challenge? Well, I think one, it's important to hear from all of you, right? Again, in mental health care, there's no one size fits all approach. It needs to be adjusted to the local context. We need to engage with people. We need to, understand how they explain symptoms. We need to understand what solutions they find. So we really need to listen to all of you. And I think partly we did this today through Mentimeter. I mean, we're not going out and just listen to people through Mentimeter, but this is how we can now start to think how best we can design interventions that really fit the needs of our population and how we can target the mental health treatment gap. The second thing I want to say is that I think the part of the future of problem solving here really is by looking at different countries and contexts. And I think the field of global mental health is really made to explore this in particular. And I'm really excited to hear from Vikram now, what we can learn from low and middle income countries, especially nowadays, in a time that America's mental health system is failing. And the pandemic has only worsened the outcomes, right? We know this. So let's look at this important point in time, and let's understand from Vikram what low and middle income countries do and what we can learn from them. Vikram, the stage is yours.
Well, thank you very much, Rick. And I think, I'll just take up from where you described this crisis that America's mental health care system is failing, and really, remind ourselves the extent of that failure by quoting my dear friend and former head of the NIMH, the world's largest mental health research funding body, and you can read the quote yourself, indicating that no matter how much money we have spent on mental health research or indeed on mental health services, and in the US, in fact, we spend more per capita on mental health care than actually any other kind of healthcare for any other disease area, you can see that every metric for mental health problems has only worsened. And this is in sharp contrast, in fact, to any other area of healthcare, whether it's cancer care or cardiovascular disease or even Alzheimer's disease, where you'll find that the incidence and the burden of these conditions has actually been falling, but not when it comes to mental health problems. So there are many important reasons, and I think that's really the key thing that I want to start with, is that unlike other areas of health, physical health problems in particular, all countries have failed to address mental health needs equitably. That is to say, proportionately across the population, and therefore all countries are developing really when it comes to mental health problems. And the question we have to ask ourselves is, why is that the case? And I have many different reasons in my mind built around my own observations of working in many different parts of the world over the last 25 years. These are the main reasons. First of all, I think the narrow binary biomedical framing of mental health into categories of disorders is simply not grounded in science. It isn't the way mental health is actually experienced in the population, which, as Rick mentioned, is really as a series of different dimensions, such as the dimensions of impulsivity, of memory, of mood, and so on and so forth, rather than some kind of artificially constructed diagnosis that is used in psychiatry. There's a lack of attention in prevention and care programs to social determinants, which we know are incredibly important, both to understand the origins of a mental health problem, but also what comes in the way of recovery. There's a lack of a life course approach, even though we know that early life experiences, particularly adversities in early childhood, but also adversities during adolescence, play a very important role in the emergence of mental health problems. But yet we treat a mental health problem in an adult as if it's occurring in a snapshot in time in that person's life. There's a lack of skilled providers if we consider skilled providers only as those who have MDs and PhDs. Certainly the lack of skilled providers, even in a country like the US, which has the highest per capita number of mental health professionals on the planet, but yet huge sections of the country have inadequate numbers of providers because most work in the private sector and in urban metropolitan areas. Twin to that is a reluctance to seek help from professionals, particularly from the very groups who are at greater risk of mental health problems, such as young people and people of color, and also low-income groups, for a variety of reasons, not least, most importantly, is the cost of care. And all community resources have been systematically disempowered through the medicalization of every aspect of mental health problems, such that, for example, community health workers who play such an important role in healthcare in other aspects of health have never been considered as being potential agents for mental health care delivery in any part of the world until recently. And this is where the story of global mental health comes in, which is effectively the mental health sub-discipline of the field of global health, where the energy is really largely around achieving equity in mental health, in both the realization of good quality mental health, but also in access to good quality mental health care for all people worldwide. The field really has a very long history, but I would say that a key milestone in the emergence of the field was in 2007 when the Lancet Medical Journal published a series of articles that I co-led, which documented the enormous unmet need for care for people with mental health problems around the world, but especially in low-resource settings. And we ended with a call to action that what we needed was not more discovery science, but actually the scaling up of what we already knew worked, built around the principles of cost-effective interventions and a respect for the human rights of people with mental health problems. Soon after that, the NIMH led the grand challenges in global mental health. I actually co-led the Scientific Advisory Council of this initiative, which was a research priority setting exercise, which sought to identify the leading research questions which, if addressed, could shift the needle on the global burden of mental health problems. Again, not surprisingly, even though we consulted more than 400 practitioners, scientists, and civil society advocates, many of whom were neuroscientists, the key research questions were implementation ones. That is to say, how could we do better with the knowledge we already have rather than invest in discovery science for discovering completely new things, for example, genes or molecules for treating mental health problems. 10 years later, and thanks to nearly, if not more than $1 billion of new money to back this research agenda, I can tell you that we now know today how to deliver clinical and preventive interventions in an affordable and acceptable way in any resource setting, even those which have no mental health professionals, such as the one that you can see on this slide from Zimbabwe, where the woman on the right is a grandmother from a local community who's been taught to deliver a brief CBT-based psychological intervention called problem solving, which interestingly enough is actually the title of your conference. And she's delivering it to the mother on the left-hand side on a bench that's been set up outside the primary health center, which you can see behind. The woman on the left was referred to the grandmother to actually receive problem-solving intervention for her depression. I have worked for the last decade and a half with one of the world's leading pioneering organizations in this community mental health approach called Sangat in India. And what you can see here is just a series of different randomized controlled trials, which I'm sure many of you know is the highest order of an experimental evaluation of a novel health intervention. And you can see we've evaluated a variety of different mental health interventions for a range of different mental health conditions across the life course, from prevention, for example, this one here, in schools, for preventing mental health problems in adolescents, all the way through to treating mental health problems in older people, as well as in children, for example, with autism, and of course, everything in the middle. This large body of evidence, in fact, how large? I can tell you that just last month, the Cochrane platform published the latest systematic review on mental health care innovations in low and middle income countries and identified 95 randomized controlled trials, making this probably the largest body of delivery science in the area of mental health that exists today. And this has redefined mental health care by redefining what comprises a mental health intervention. For example, these are brief interventions that target both psychological skills for specific mental health dimensions, oftentimes combined with addressing social determinants of mental health problems. They're delivered pretty much anywhere where the person is rather than where the mental health professional is. In my own work, many of these interventions have been delivered in the homes of individuals with mental health problems. It can be delivered by anyone in the health workforce and even beyond the health workforce who is authorized to deliver mental health care, provided that they're working in a coordinated and supported way by the rest of the healthcare system. And there is, of course, attention paid to the training and quality assurance and supervision of these individuals. This evidence has transformed mental health policy globally. 10 years ago, I would have found it unimaginable that the World Health Organization, these two reports here, the World Bank, this report here, and national health policies in countries such as the National Mental Health Policy of India would have embraced the idea of using community-based providers with no previous training in mental health to be delivering both clinical and preventive interventions for mental health problems. And this takes me to where we should be headed in the future, particularly in wealthier countries as well. In 2018, I led the Lancet Commission for Global Mental Health and Sustainable Development, and we assembled all of this diverse evidence and came to the conclusion that the single most important action that we needed going forward was actions that sought to strengthen the base of the pyramid of care, both through community health workers and peer support specialists who are working within the healthcare system. And I can think of many other kinds of providers like nurses, midwives, and so on. But also, even beyond that, equipping citizens in the community to be able to initiate care whenever they thought that someone close to them or someone they were encountering in their work might be having a mental health problem. Would this be acceptable in the wealthy world? Well, about 3 or 4 months ago, the RAND Corporation in the US published a landscape analysis on how to transform the US mental health system. It documented the complete failure of the US mental health system to achieve the kinds of goals that it should have achieved, given the amount of money that it was spending and the amount of mental health resources it enjoyed. For example, the state of New York alone has more mental health professionals than the whole of Africa, from Cairo to Cape Town, and yet vast numbers of people in New York were unable to access mental health care, or as Rick said, found themselves in prison or on the streets. And what did they recommend? Well, they recommended exactly what the developing world is scaling up: the training of non-specialist providers, not just because this would greatly expand the footprint of the mental health care system into the community, but would also allow specialists to work at the top of their license. How will we achieve this? Well, we certainly cannot use the old-fashioned way of training frontline workers in in-person workshops with experts. This approach, which has been used for decades, is simply not scalable for obvious reasons. There are millions upon millions of workers who need to be trained and only a handful of experts. Not only is there a great constraint on time, how can you train millions and millions of workers in a quick way? But also there is a shortage of experts. And the good news is we have a variety of solutions for these challenges, not least the use of digital solutions to enable frontline workers to learn, master, and deliver psychological treatments. Please know, I'm not talking of an app for people with mental health problems, which has been what the focus of digital mental health has been for 2 decades. No, this is actually a digital platform to build the workforce. It's a provider-facing digital platform and indeed a system-facing one. It comprises a suite of digital tools, beginning with off-the-shelf tools like learning management systems, where we apply a systematic methodology that we have developed over the last 5 years to transform an evidence-based treatment manual, one of the many different treatment manuals that have been used in the randomized controlled trials, into a competency-based video delivered curriculum that is mounted on a user-friendly learning management system. We have built a science of how to assess competencies and deliver those competency assessments remotely, a science of how one can quantify quality assessments of psychotherapy being delivered by these frontline workers, and how this could then be done remotely using digital tools. Supervision, and particularly peer supervision, so that you don't need experts to support the delivery of care. And then as larger numbers of health workers are credentialed after mastering their treatment, using large amounts of data, not only to evaluate the impact on population mental health, but to use data science-driven prediction modeling to refine treatment selection and provider training. We started with this initiative several years ago with a 6-session treatment for severe depression built around the cognitive behavior principle of behavioral activation, a treatment that we had developed and evaluated in a large randomized controlled trial in India. And with NIH support, we began to digitize the learning of this treatment and have just completed the largest randomized controlled trial of ASHAs, who are community health workers in India, comparing digital learning in 2 different formats, completely self-guided and self-guided with remote coaching, compared to the gold standard of in-person training. Through this method, this trial, we have developed a methodology of how you digitize manuals for frontline workers and how you assess competencies in a remote, valid way. We will actually be unblinding the results of this trial on December the 6th in India. But this experience of effectiveness of interventions has been so exciting for the global mental health community that I was delighted that last year we began a partnership with the Meadows Mental Health Policy Institute in Texas and the American Psychological Association, which is the world's largest professional guild of clinical psychologists. And we agreed that we needed to bring these brief interventions delivered by community health workers to the world's richest country. And so we initiated this collaboration. And I think for the first time ever, an intervention that was developed in a developing country was adapted for the US cultural context. I think usually it's the other way around. But here we took the Indian Healthy Activity Program, adapted it with the partnership of the American Psychological Association for the treatment of depression. These 2 curricula have now been fully digitized and will be launched in January next year in Texas, thanks to our winning the $10 million Lone Star Depression Challenge Prize, the Lone Star Prize for the Depression Challenge, which will roll out community health worker depression care in Texas in partnership with primary care and mental health providers in a collaborative care model in that state. Ultimately, This model, and of course, we expect to enhance our offerings to go to trauma, drinking problems, youth mental health problems, autism, and so on, as soon as we get the kind of resources we need to build these curricula. And by the way, the products are not just curricula, they include the competency assessments and the quality metrics as well. We also have grants to develop the digital supervision tools in partnership with the Boston-based tech company called Demagi, which is the world's largest community health worker tech company. In doing so, what Empower does is it takes the frontline worker who is a naive learner, after doing the online learning and they complete the competency assessments, they become competent learners. They then start using the digital supervision platform to practice the delivery of this care to real patients until they achieve the level of quality that then allows them to be credentialed. And once you have credentialing, you can then join other credential workers and begin to deliver this care to the wider community, to patients who are referred to you. And as you gain expertise, you can then ultimately become an expert who can support the next generation of learners. As you've heard from Rick, the pandemic has fueled the demand for mental health care. The system that existed before the pandemic was already extremely unlikely to meet, was just simply not meeting the needs that existed even before the pandemic. And it'll be extremely unlikely to actually respond to the rising demand, so that the levels of unmet need will grow incredibly fast in the months and years ahead. What Empower is seeking to do is to address this rising demand by transforming the mental health landscape by scaling up the very exciting implementation science evidence that demonstrates the effectiveness of community health worker and other lay health worker delivered brief psychosocial interventions for the prevention and care of mental health problems, so that we can vastly increase the numbers of people who are helped. Ultimately, I end by saying that what the science shows us, the need to reframe mental health as a global public good, not just as a biomedical entity, but something that is of universal importance to all human beings. It's indivisible, of course, from our physical health. It's important, especially to young people, and it's never been more important thanks to the pandemic. Thank you very much.
Thank you, Vikram. We did get a number of questions already, which I'm sure we might not be able to answer all. But let me start by asking, and I have you heard talking about this quite a number of times, but now, you are very fierce advocate for global mental health. What would you now tell your neuroscientist colleagues and your psychiatry colleagues on both sides of the Atlantic, why we need to invest in global mental health and not in neuroscience research, and why do we need to invest in community psychiatry and not in psychiatry? Because people, psychiatrists sometimes now fear that there is some competition with community health workers.
Thanks, Rick. Well, first of all, neuroscience is central to what we're doing. Actually, neuroscience, what's interesting is we're actually writing a piece called From Circuits to Communities, demonstrating how networked neuroscience is the foundation of these brief, mechanistically informed psychological interventions that are not complex packages of thousands of things which don't tell us what, give us no idea of what actually is working, but instead are built around neuroscience-derived understandings of dysfunctional brain networks and what that does to deep cognitive phenotypes. For example, maladaptive withdrawal in the face of stress that leads to low mood, and the intervention is behavioral activation. There's a complete continuum. And for the first time, actually, we have a complete continuum from the brain to the community. What it's bypassing is diagnostic psychiatry. And diagnostic psychiatry is going to have to actually reform itself. Otherwise, it will soon be, in my mind, irrelevant to the mental health field. The focus on these algorithmic diagnoses that have no grounding either in neuroscience or in epidemiology or in genetics is, I think, the single biggest problem that we are facing. And I think most forward-looking mental health professionals have recognized that. Most research funding bodies have recognized that. No longer do you need a diagnosis for an NIMH funding. This is unthinkable. 10 years ago, you needed a diagnostic categorization of your patient group. Today, you don't. And I think that's an reflection of how people are moving away from diagnoses. I think ultimately psychiatry is going to have to smell the coffee and move with it. If it doesn't adapt, it will become redundant. But I believe that's not what's going to happen. I think psychiatry is waking up to the reality that actually the future of the field lies in a much more person-centered approach rather than a protocolized diagnosis-focused approach. And I think you will see the excitement around precision psychiatry as being one way in which the kind of, it's fascinating. When I talk of community mental health, I'm actually talking of the most cutting edge kind of psychiatric practice you can think about. It's not a simple version or dumbed down version. It's actually a very science grounded version.
Yeah, that's great. I think as psychiatrists, we are the ones talking about change to our patient all the time. But at the same time, I don't think psychiatrists are particularly made for change at times. So I'm really glad there is so much movement in the field. We got a question about in the United States, the sentence "How are you doing?" is often not answered truthfully or neglected, and just answered with thanks. But really, people don't seem to care about the answer. So what can we do to help people answer truthfully and to facilitate that people answer it more truthfully?
Answer truthfully about what, Rick? I didn't understand.
How are you doing when in social situations when you start the conversation and you start, how are you doing?
You think people are superficial? Well, in a sense, that's what you do, right? I mean, if you're meeting someone in a very, very random way, when people say in the US, it's a greeting. It's a kind of a everyday greeting. How you doing? And the usual answer is I'm good, because you've got, no one's expecting you to suddenly listen to a story of being unwell. But I think the question is whether closer acquaintances and friends say the same thing. I don't think they would if your question comes across as being authentic and that you're really interested. And I would always go beyond just how you're doing. I would actually say, if I thought that somebody close to me was having a difficult time, I'd be more specific. Hey, Rick, is everything okay? Rather than how you're doing. How you're doing is a kind of a, everyday random encounter greeting, which you get in a newsagent shop or, in a supermarket. But if it was a friend, I wouldn't just say how you're doing if you thought someone was having a tough time. And I'm pretty sure that if you asked a more targeted question, the person would say, okay, you've noticed something. And yes, actually, I've been having a tough time over the last week. Or no, actually, no, it's good. I'm cool. Why do you think that?
Yeah, I think I can add. I had a few incidences in America where I think you can actually play around with it a little bit. I had a few incidences in supermarkets where I didn't just ask how are you doing and started packing my groceries, but I was actually looking a person into their face and just like literally waiting for the response. And then the person looked at me, it's like, wow, you're the first one who seems to be really interested in this. So I think what I'm saying is, it's worth just playing around with it, but also acknowledging we're not like doing therapeutic sessions at a checkout desk in the grocery store. There's a question about how can we teach young children a better understanding of mental health balance, especially with younger kids and the younger generation now growing up with social media, Facebook, Instagram, which can also pose risks to their mental health. Like how do you teach about mental health, especially the younger generation?
Well, I think, there's a large group of people who've been working around creating more awareness about mental health by focusing on social and emotional competencies, such as, for example, how do you control your anger, why anger can be damaging, how and when you should actually express your mood to other people. I think there are, I'll give you one example of a terrific initiative that Sangat was involved with, which is a global one called Zippy's Friends. It was an initiative to really teach children in primary school a language of emotional competencies and being able to have a sharing in circle times with kids about what's going on in their lives and feeling comfortable sharing those things. Obviously, with adolescents, which is a very important demographic age group for mental health problems, because this is when most mental health problems emerge, the teaching of social emotional competencies such as emotional regulation skills has become a very common approach that is used. There's a lot of work going on around, for example, teaching problem solving, and that's been a lot of my work in India. We see problem solving as a very effective emotional regulation strategy, because I don't know how many of you know, but we have an incredible new developmental science discovery in the last decade that the limbic cortex, which mediates emotions like, for example, rage and thrill-seeking, matures 6 to 10 years before the prefrontal cortex, which is the decision-making part of the brain, which is why we now understand that young people are almost biologically primed to take risks. And so in one way to reduce harmful risk-taking behavior, teaching emotional regulation skills can be very useful. So that's another example of interventions that are being widely used in for young people.
Yeah. We have a question about the relationship, the association between mental health, religion, spirituality, faith. And I can say from my own work in Ghana and Kenya, it comes up quite often indeed. I'm not sure what experiences you've made in India, but can you tell us a little bit more about the association between faith, religion, and mental health as you encounter them?
Well, you know, before the advent of the Renaissance, the Enlightenment, sorry, and the the development of modern medicine in the 18th century, and certainly around the time that Freud was around, until then, actually, these were inseparable. You know, in every culture, in every single culture, one's spirit world, which of course was linked to religion, and one's mental health were actually often two sides of the same coin. And which is why when one had mental health problems, one often invoked spiritual or religious explanations for those mental health problems, and indeed religious and spiritual therapies, if I can call it that. This continues to this day, by the way. It's true as much, you know, we often think only of Africa and Asia where this happens. This happens here in our backyard in the US. Amongst people of color, for example, those who come from Central and South America, African-American communities, but even white communities, when people are distressed, they often turn to God. They often turn to their pastor. And so I think the reason that is the case is because one's mental health problems are deeply influenced by one's social conditions. And we often look at God to explain our social conditions. If we are facing a lot of misfortune in our lives, those of us who are religious will often see this as a result of some kind of divine action, or we will turn to God to help us understand those misfortunes. And so it's not at all surprising that our mental and spiritual health are so deeply intertwined with each other. And the big implication of this, of course, is when I was talking about community-initiated care, one of the important sectors that we should be working with are, in fact, pastors, priests, and a myriad other varieties of religious healers, because they, in fact, are likely to see a very significant proportion of psychiatric morbidity amongst their congregation, particularly those who come to them for individual help and support.
That's great. And maybe one more question before we wrap up and go to the take-home points. There's a question about in our workplace, in our school places, you know, maybe we don't want to become a community health worker, but we still want to be a community-based mental health advocate. So how do you recommend people start thinking about how to become a community-based mental health advocate? And what are some of the resources you recommend?
Well, there's actually a lot of internet-based resources. You know, to be ultimately a community mental health advocate, in my book, quite honestly, is being a good citizen. You know, a good citizen who will be aware of and sensitive to the mental health of people in their intimate circles, but also what's going on in the world around us. And being able to respond in a way that is non-judgmental, has all the kind of skills that typical psychotherapy does, listening skills, being non-judgmental, not trying to be a savior, but just providing a space for someone else to share what's going on in their lives. Now, obviously, you can do more formal training, for example, in mental health first aid. Mental Health America, in fact, has a program to do that. It's a kind of a very brief intervention that which you can learn the skills for. Certainly, if you hang around a little bit, Empower is going to be producing such a curriculum, which will be open access. By the end of next year, we should have that curriculum live on our platform. But you know, there's a lot else that's already available on the internet that you can search for.
Good, that's great. And I hope people will look up you at Harvard. You're now running the Mental Health for All Lab, where you also have what are details about all the initiatives you are engaged with in length. So I hope people have a look as well. Harvard has a lot of great resources, and so maybe we can wrap this up. You know, maybe by talking about the 3 take-home messages. What do you want people to take out of this talk? And maybe you can also end with a recommendation of how to take care of yourself.
Well, I think mental health is simply too important to be left to mental health professionals alone. Mental health is, for me, the single most important valued asset of my being. It's certainly more important than the color of my hair or how tall I am. It is really the sum of what makes me the person that I am. And therefore, it is in my own best interest to be very conscious of my mental health at all times, to acknowledge when my mental health is not as good as it could be, and to take specific actions and steps to actually promote my mental health. It is also in my interest to be aware of the mental health of people around me, because that will affect me. And that in caring for other people's mental health, I not only do them good, but I also do myself good.
That's really great. And I can just encourage everyone, and this is my wrap up as well, to actually go out and talk to people and ask questions and listen genuinely. I think, there, as much as it sounds like a challenge for some potentially at the beginning, it's really rewarding eventually. And you will have really, really great interactions with people. So we hope that you enjoyed the conversation, and thank you so much for tuning in. And with this in mind, I give Debbie the last word.
Thank you so much. I think Karim will actually be giving us a brief conclusion.
Rick and Vikram, I want to thank you very much for these excellent speeches and the lively discussion. It was great to have you here today with us. As we could learn, one's mental health is a multidimensional topic that has to be cared for and cherished. Issues have to be addressed right away, and there are many ways to do that. But let's remember that in our everyday lives, sometimes it's a very good way to support each other. It's just like to talk and to listen to each other. Thank you for sharing your views on this. And for those who would like to learn more about this topic, I would like to draw your attention to the German American Conference podcast we produced on the topic of powerful minds, the challenges of mental health in a post-pandemic world, with Anne McElvoy and Dr. Rick Wolthusen. Please stay tuned in for the next panel, brand new forms of political participation, which will begin in a few minutes. Thank you very much.